Thank you, Mark. Thank you, Mariana. But most of all, thank you, Dayna, for bringing us together and making this happen. It's been a really exciting day, and you know you're at the right conference when you listen to the other speakers and you just want to get up and say, well, touching on some of the really interesting and complicated, rather than give you my presentation, I want to respond to all of it, right? And I may do a little of that. For example, that issue of scalability versus fidelity. I dream about that. Sometimes they're good dreams, sometimes they're not. But anyway, so I'm here to talk about Reach Out and Read, a national program, and I'm going to tell you about its scope, in which primary care providers in that pediatric primary care environment help families, help the children that they love grow up with books, with reading aloud, with language and love. So how do I advance here? Do I need to use the clicker? I just tried clicking on the computer. That didn't work. So let me try the clicker. Oh, sorry. Okay, excellent. And in doing this, we are trying to give young children a foundation for success, incorporating books into pediatric care, encouraging families to read aloud together. I'm not going to belabor the question of why primary care, because you all know it already, and several speakers have said it so eloquently and articulately. We have the access, we're trusted, people come in. What I most want to emphasize about the way that Reach Out and Read has grown and developed, though, is that the way that we're embedded in the existing healthcare system, with all of its beauties, whatever it is, and we've already talked about some of its problems, that state of being embedded has allowed us to be both cost-effective and scalable. And the more closely we can cling to that system, the more accessible we are to other programs. Quick introduction to Reach Out and Read. At routine checkups, at well visits, and I know there are lots of people in this room already who know it, but starting in infancy, ideally starting at birth and continuing through 5 years of age, the pediatric providers, the pediatricians, the family physicians, the nurse practitioners talk to the parents about books, looking at books, reading with young children, model how you do it with a 6-month-old. Look at the baby, there's the baby's nose, there's your nose. Model it in the exam room and encourage parents to build book and language and story-related routines into their days with children. And with that goes a beautiful new developmentally and culturally appropriate book to take home. This fits into the clinic. We take advantage of waiting rooms if we can and create literacy-rich environments. We take advantage of having the book in the exam room to do a little developmental surveillance when you hand that book to the 6-month-old and she grabs it with her whole hand because she doesn't have a pincer grasp yet, and she successfully transfers it to her mouth because that's what she's going to do. You know, you see some motor skills, you see whether there's parent-child ability to follow the cues. You see a lot. We use the books in the exam room. I'm going to show you Reach Out and Read site visit.
Welcome. My name is Marilyn Augustin, and I'm a pediatrician at Boston Medical Center. I'd like to show you how a family experiences Reach Out and Read at our clinic and thousands of other clinics around the country. When the family checks in at the front desk, the staff member begins the Reach Out and Read process by commenting on the book the child will receive in a few minutes.
This is Amir.
Amir, okay. You're all set. Amir, you're going to get a book today. It's your 18-month visit. So have a seat and someone will give you the name for you.
Many Reach Out and Read clinics have a literacy-rich waiting room. A little table and chair creates an inviting space for a child and parent to sit and look at one of the gently used books that are available for children of all ages to read and take home. Sometimes volunteers are available to read aloud to waiting children.
I'd like to give him a book and see if he wants to take a look at that, check that out. Wow, look at that. Nice job. One of the reasons we give the books is a great time to expand his language. So he might know the girls' names and your names and cup or apple, but when you read a book with him, he's going to hear about coconut, he's going to hear the rhyming sounds, and that really helps expand how he's thinking about language.
You want to read? All right, let's read. Skit, scat, scoo, dot, flip, flop, flee. Everybody running to the coconut tree.
Amir has a book to take home to remind them to read together often. Amir's mom and dad will read to Amir and Nyla and his sisters every night because they trust the advice from their clinician. They understand that reading aloud will put their children on a pathway to success. Multiply this by the thousands of children who visit this clinic every year and the millions who are seen at Reach Out and Read clinics around the country, and you can see the difference that Reach Out and Read makes every day in the lives of young children and families.
When you give him the milk, he'll probably ask you for a straw. When he's finished, he'll ask for a napkin.
So I want to say a few things about implementation because we just heard such a great talk about some of the issues that come up with implementation. Thank you. I want the rest of the panelists to appreciate my efforts in getting all the text sorted out for you, because without my extensive training, you'd be in trouble. So a few things to say about implementation. This is meant as population-level primary prevention. We believe that every child growing up in every family needs this message, this modeling, and this help. But obviously, we target most of our first energy and attention to clinics which serve a high number of children and families at risk. The individual sites around the country are supported by an amazing network of, you heard Mariana say that she's the medical director of Reach Out and Read Illinois, by an amazing network of regional coalitions and programs that support those sites, that work on them to improve fidelity, that work on fundraising on that local level, and that regional network is in turn supported by our national center. We talked about what kind of buy-in a clinic has to show, and there are similarities. We require buy-in from the leadership of the clinic, the executive leadership. We need a medical champion on the staff who takes this to heart and becomes known as the crazy book person. I serve that role at my clinic. You know, people see you coming and they say, I gave him the book and I talked about the book. I did. One of our strengths in implementation has been that this program was developed in and is congruent with the culture of the kind of pediatric settings where many of us practice. Busy places without a lot of extra storage space, with waiting rooms where families wait longer than we would like because people have complicated lives. It fits into those clinics. It makes sense to those primary care providers, and that's been tremendously helpful in expansion and implementation. And so has the way that we have carefully tailored the program to align with the goals that are, for example, set out in Bright Futures, in which the American Academy of Pediatrics tells us all of the things that we need to do to have a successful well visit at any given age. So my goal when I'm sort of trying to talk about this program with clinicians is not to convince them that I've got 5 more boxes to add to their checklist, right? My goal is to say, what do you care about most about doing in the primary care visit? How can this book help you do it better? Everything from talking about speech and development to talking about bedtime routines to getting a sense of the parent-child relationship. It's to help you do what you're already trying to do more effectively, more efficiently, and to give the family a really concrete tool to take home and try to carry out some of the advice that you've given. And also, it's the opposite of a deficit model. When you work with a book, when you give a child a book, the message to the family is clearly a message of believing in that child's brain, believing in that child's potential, and believing in the parent's will and the parent's ability to help that child grow and learn. it is also a way of helping the primary care providers build bonds with their patients and families, and even perhaps as we're trying to help parents feel a sense of agency and self-efficacy, it's also been said that we sometimes help the primary care providers who, heaven knows, as we've already talked about this morning, have some struggles of their own, remember why they went into this business. So some of the messages that we're trying to say to parents, some of the messages that are coming across, we hope, in this modeling, and some of what we say explicitly and some of what we say implicitly, is that you are your baby's first most important teacher, and that what you're teaching is language and words and vocabulary and communication, but also responsiveness and serve and return, and all of the interactive values that we most want parents to be thinking about from the very beginning, that we're trying to put that in the context of establishing daily routines that are positive and rich in language, and that those routines will help your child grow and help your child develop resiliency and handle stress. But our single most important message, and I can say this in about 9 languages, is that your baby, your child, will love books because your baby loves you. This is not about trying to teach children to read early, heaven knows. It's about using that connection and that attention to make a connection as well to the written word and the page and stories, and that in turn, that understanding of books and that language will indeed help your child eventually be ready to learn when your child gets to school. Now, I do have, I think, the world's largest collection of reading Madonnas. There, you know, if you do European art up through the Middle Ages and the Renaissance, there's really only one baby you can look at. And one of the ways that the Holy Family is depicted repeatedly is there are breastfeeding Madonnas, there are knitting Madonnas from Germany, which are fascinating for those of us who are knitters, but there are also reading Madonnas. And if I were giving you an art lecture, I would ask you whether you thought that this painter, whose name is Foppo, had actually ever seen a baby, given the proportions. But perhaps more important, you might take a look at where's the mother looking, where's the baby looking. What's our message to clinicians who are already busy with already long checklists? Why do we have 30,000 primary care doctors, nurse practitioners who have undertaken this training and undertaken the delivery of this program? There are a set of similar messages. They also want to foster those parent-child, caregiver-child interactions to promote development, to enrich the language environment, to reduce disparities, to help families build healthy routines and supportive relationships which can buffer toxic stress. We want to partner with parents. We all know we want to do it. How do we do it in those 15 minutes that Rahil described so eloquently? And what I would say is when we explain it properly and model it properly, this gives you a way to do it, and it gives you something, a little spot of color, that goes home with the family and actually, in a small but real way, changes the home environment. We provide books in 21 different languages, including Arabic, Chinese, Russian, and Spanish. We do most of our materials in many languages. We're in more than 6,000 clinics, as I'm going to tell you, so we try to meet the needs of the families and the populations in all of those places. We have extensive peer-reviewed research, which I'm not going to dissect out for you in great detail. Every one of these articles is up on our website in our research summary, and ask me and I'll talk more about it. And some of it was done by Alan, so you can ask him as well. But what the research has shown is that parents are significantly more likely to be reading to their children if they're getting the Reach Out and Read intervention, 2.5 times more likely, that they're much more likely to say they enjoy reading aloud. And you test that by asking open-ended questions. What are your 3 favorite things to do with your baby? And you see if people spontaneously mention reading. That they're twice as likely to read to their children frequently, and also, and this is the study that Alan can tell you about in more detail, that if you test the children's vocabulary in the preschool years, and this was in a high-risk group of children, Reach Out and Read was associated with a 6-month advance improvement in their receptive language and a 3-month improvement in their expressive language. So we're seeing effects on parent behavior, parent attitude, but also on child language. This is one of the studies comparing frequent reading aloud 3 or more days a week in the intervention group and the control group. This is Alan's study that I'm talking about, showing the 6-month and 3-month differences in language in the preschool years. So we are talking about scale. We are delivering this program to 4.7 million children every year. That's a big chunk of children, and it's a very big chunk of the children growing up in poverty. We've got over 32,000 medical providers who are trained and participate, and they're giving 7.2 million books a year to those children at their almost 6,100 programs in all 50 states. We expanded a lot. We talked a lot about this. You grow, there's a little bit of a feeling of, is scalability. Then do we have to go back and make sure that we've got fidelity? Well, we don't have as much fidelity as we'd like, but we've got scale. Can we turn those ships and help those programs that want to do it? So we've expanded a great deal. In 2014, the American Academy of Pediatrics put out a policy statement calling literacy promotion an essential component of pediatric primary care for all children, so thus saying that this should be part of delivering primary care and reviewing the evidence around Reach Out and Read, and calling it an effective evidence-based intervention, which really brought us to a place we'd always wanted to be, in which we were more fully integrated into primary care. There's public funding of different kinds all over the United States, in many different states, but you also heard mentioned this morning the first actual involvement with Medicaid, which is very exciting for us, right, and what's going on in Oklahoma. Okay, here's somebody who actually had seen a baby. Raphael, and I just want you to notice that this is a painting of joint attention. This is not a storybook, this is not a read aloud poster, I'm sure it's a religious book, but look where the baby's eyes are going and look where the mother's eyes are going. We've also gotten involved with early math, and we're using math to give parents other things they can talk about when they look at books with children, big, small, counting the things on the page. We're looking forward to a great deal of attention to program quality and fidelity, and to further research and to thinking about policy. And we're actually developing an initiative called the Reach Out and Read Innovation Lab, in which we are trying to build a network of leaders to advocate for this promotion of positive language-rich caregiver-child interactions and relational health through primary care. We're developing a best practice framework, again anchored in primary care, that can be scaled to population level, and we're trying to discuss and disseminate the research and best practice and experience. One more, here's somebody who actually was interested in how a child turns pages and handles pages. You can learn a lot by looking at these. What I want to say in conclusion is that literacy is not a small thing. When we talk about trying to help families foster early literacy, we're actually talking about promoting multiple aspects of development. We're actually opening a whole range of important combinations. We're promoting social emotional development as well as vocabulary. Maybe we're even helping the social emotional development of parents and providers, because children who are ready for reading and ready for literacy are children whose brains have been supported in their early growth and development in multiple domains, in high quality language rich interactions, in serve and return, in routines, in face time, in lap time, in time that's not about screens, in ritual, and also in the exposure to print and pictures and story and sequence, all of which leaves you with positive associations with books and reading, with stories, which you first heard in that safe place, in that well-known voice, but also ready to do the work of learning to read when it comes time for school. Here's another child turning pages. So my final message to you is that in so many ways books build better brains, and that in so many ways reading is a triumph of the early brain, bringing together vision, cognition, memory, phonological awareness, phonemic awareness, vocabulary, sequence, story, motivation. For all this to work, a lot has to go into taking care of that child. And I think I'm supposed to take your questions now, but I would again close by thanking Dayna and saying that it's just been a joy to think about all of these books going from the providers to the families and those interactions that Raheel talked about, which is where the soul of what we do always resides, and then going home with the children out of the clinic back into their lives. Thank you.
We'll have time for 1 or 2 questions between each speaker.
Had Botticelli seen a baby? Botticelli had seen a baby. Look at those thighs.
I'm Nancy Silverman. I'm a speech and language pathologist in the Chicagoland area. And I just want to thank you for everything you're saying is so true. And I just want people to know that parents who may be not speaking English and you give them a book that's in English, it's okay. Because what we really want is for the parent and the child to have that interaction, just talking about the picture. And what we're saying to parents is to please use your best language with your kids. We don't want them using English, a broken English, because it's so important for them to hear the best language that they have to offer.
Absolutely true. It's a really good point, and it is part of our training. Ideally, we have books in the language that the family speaks, or bilingual books if we can, because of course it's an amazing experience to reach into the closet and find the book in Cambodian and have the Cambodian family delighted by it. But if we also have some wordless books, we have counting books which work very well if they're not in the right language, because 1 apple, 2 bananas. But the message to the parents always has to be to talk, read, sing in the language in which you're comfortable. Children need to be exposed to rich, syntactically complex language for their brains to develop, and then they will. We know that when they're 3, they will be able to do what I have been trying unsuccessfully to do for the last 20 years and learn a new language perfectly.
Excellent presentation. The audience may not know, but Marilyn Augustine is from the south side of Chicago, grew up in the back of the yards, and got services at University of Chicago Settlement House. But I was part of the project that Golova did. And at the beginning of Reach Out and Read, there was concern, when do you start books? And the major thing was that we discovered during that project that you start from the beginning. You start in the nursery, you start at 1 month, and you work on parenting proactively from the beginning and talk to your baby, play with your baby, interact with your baby. And those things are priceless because they are not one score, are not one target. And I think the models that you suggest, from Reach Out and Read to Healthy Steps to the things you pioneered in primary care at BU Medical Center, need to be cloned. And can you discuss why you could implement it in BU and other places struggle?
Well, there's not one answer to that, because there are probably, I'm not sure there are as many struggles as there are clinics, but there is certainly a variety. I should say first, I should say in tribute that Reach Out and Read was part of one of the components of Healthy Steps from the beginning. They kind of grew up together. At this point, since we're in in more than 6,000 clinics and practices and hospitals, we've had a lot of experience with why sites struggle, both with why they struggle to sustain the program, which is about all of the same things that we've already referenced this morning. It's about turnover in clinic culture and often about money. And it's about having that medical champion and that coordinator who really buy in. It's also often about having an overall kind of functional clinic. Someone did a study some years ago and discovered that health centers that were generally dysfunctional had less strong reach out and read programs than health centers that were, in the estimate of the people who worked there, more functional, had fewer leadership transitions, were in less trouble financially. So there are a lot of settings, and of course the challenge for all of us is that some of those most troubled, most marginal facilities take care of some of the kids we most want to reach, right? We all know that. And it's so, we can't, and I think Raheel said some of this as well, we also can't just wait for a clinic or a health center to solve all its other problems, financial, staffing, logistics space, and then come to us and say, okay, now we're ready for your program. Because none of the places that any of us work have attained that status yet. What I do think I've learned, and I say this very sincerely in more than 20 years of working with Reach Out and Read, is that the program finds the right providers, that wherever you go, you find people who bring to it a sense of commitment, understanding of what it means to have the books go out into the children's homes, an understanding of the potential. And it's that local buy-in and that local understanding which makes it possible to get through the many interesting varieties of struggle. Thank you.
Are we next? Or?
Oh, well, oh, yeah.
Alan, you're going to be next. Okay, there you go.
Who knows?
Well, good afternoon. I am so completely excited to be able to be here with this amazing group. So thank you, Dayna, and thank you, everybody. So I'd like to start by talking a little bit about primary prevention. And we've kind of alluded to primary prevention in a way, but I want to, and Perri just mentioned it, but I want to talk directly about it for a minute, because in the policy world, and in the pediatric world, there is a lot of focus, appropriately, on finding and treating disease and problem. It's what we're trained to do as pediatricians, right? And those of us who are pediatricians in a lot of ways. And yet, what is just as important, and what I'd like to make the case for Reach Out and Read and for VIP, which I'm going to talk about, is that primary prevention is just as important. The idea that we're going to try to prevent something, prevent a problem from happening before it actually happens, somehow needs to be brought back to the forefront of this conversation. Why is it for early child development and school readiness? Well, it's because there is so much evidence that supports the need for doing the kinds of programs that we're talking about. But it's also because when you talk about income alone kind of predicts adverse outcomes in a way that almost nothing else does. So let's say for the sake of argument that we knew nothing else but that a child was growing up in a household at twice the poverty line, which we know represents close to half of all children in the US at this moment. That fact alone would tell us that that child would have close to a 50% chance of being behind in reading in elementary school. And that's an amazing number. For those of us who are pediatricians, right, that says it's a 50% positive predictive value. In other words, we've done our screening test. We know it's done. We know that every child, universally, certainly every child in poverty, needs the kinds of programs that we're talking about today. All right, so now I want to mention one other thing. We've talked about the importance of primary care, so I'm going to kind of talk about the flip side, which is that even though we know that primary care is really good, to engage families, we're still at a point where we are having trouble engaging families, particularly in other domains. So 2 examples is Early Head Start, which has a capacity at the moment to serve something like 4% of eligible families, and home visiting, in which there's been amazing progress. There's been a vast increase in the amount of funding for home visiting that's out there. It's led to a quadrupling of families over 4 years, and yet engagement is still a completely unsolvable issue in that there are huge unmet needs, And capacity of home visiting is about 3 to 15%, depending upon which number you look at, and the 3% is probably the truth. Okay. I'm not going to talk about why pediatric primary care is awesome, because it is. You know, if I'd had another 20 minutes, which I thought I had, you know, to like process that, I would have never done that, but I was sort of in the spot slightly. Okay, so what I want to move to is reach out and read, actually. And what I want to say is that, you know, there is a program that is the most studied, proven primary prevention program in existence, and that program is Reach Out and Read, with more than 15 studies showing impacts, at least 2 more, and I'm sure there are more, that are out there and in press at this moment. But what I want to say about it, since you know, obviously Perri just covered it, is that what is an amazing fact about it is that it actually reaches 25% of all low-income children in the US between birth and 5 years. Is there any other program that is relationship-based, that does one-on-one work, that has ever achieved such a crazy thing ever? Okay? So, stop for a second. The answer is probably no. Okay. Okay. The second thing I want to say about it is that in terms of thinking about policy, okay, Reach Out and Read has not only the capacity to reach every family, but costs $25, you know, at most, per child per year. And when one kind of thinks about the cost of programs out there, you know, to solve this problem, you know, they range from early child education programs, which are amazing, and every child needs to have them, but they cost, you know, $10,000 to $20,000 per child per year. And when one talks about home visiting, one is talking about programs that are running like $2,000 to $10,000 per, you know, child or per family per year. You know, Reach Out and Read at $25 per child per year is almost like a rounding error in the policy world. It's like we forgot, we made a mistake, and guess what? Every single child in the US has Reach Out and Read, right? I mean, it's really something to consider. Okay. On that note, by way of that somewhat somewhat multi-directional introduction, I'm going to move on to the program that I was asked to talk about, which is a Video Interaction Project. Video Interaction Project is, or VIP, is a birth to 5 program that was actually designed as an enhancement to Reach Out and Read. We actually began working on this in the late 1990s, and the idea here is that we would add a parenting coach who would work one-on-one with families, who would promote play in addition to reading aloud, since reading aloud was already being promoted by Reach Out and Read, as well as teaching and talking. The core activity of VIP is video recording, parent and child interacting together with a book or a toy, or both, that's provided by the program, followed by a review of the video to promote self-reflection, identification, and reinforcement of strengths. And I'll just kind of take you through the different components of it. One of the components is provision of toys and books in the home. And I'm realizing this is the second thing that I really want to emphasize, is that programmatically, the importance of books, and I think toys as well, cannot be overstated in their role as props to support parents and children engaging in high quality and rich language interactions, which are going to support all domains of development. So I just want to emphasize how important I think that is. This is an example of some of the toys that we give. Second is that we developed parent guides with suggested activities that guide planning, and the goal here is to promote knowledge and skills. And what's kind of cool about our parent guides is that they're mostly blank space and white space. The reason for that is because this is not about telling parents what to do. And I'm not sure we should be in the business of telling parents what to do. I think that what we're in the business of at our best is empowering parents to be able to say, you know, I want my child to be successful in school and in life, and you know, and empower parents to, you know, to go and do that in the way that they want to. So a lot of this is about planning together. And the third is the video recording and review, as we mentioned. This is happening at every well child visit, from birth to 3 initially, and now birth to 5. And I will give a quick example. And I am really, really nervous. But I'm also hopeful. It'll be kind of both. Less nervous, more hopeful.
Sound, sound. talking about the colors, we can talk about the sound, their different textures, so you see how things change. What's that over there? A fishy. What color's the fishy? It's pink, right? Your favorite color besides purple? You're constantly talking to her throughout the whole sharing of the book. It's pink. I love this part. You related it back to something that's very much to her. What would you like to continue doing with her at home with the book? What would you do? The same thing, play with her, like show her the different colors. Oh, and also like I put some stories, Absolutely. See you soon.
So I'm going to get to talk to you a little bit about the research that we've done, and then I'll talk a little bit about our implementation and scaling efforts at the end. We've had the opportunity to do a couple of randomized control trials. One of them, which is really cool, is we got to do something called a factorial randomized control trial, where we randomized at birth and randomized again at age 3. And that meant that families could have received this program either early, late, both, or neither. So that was an interesting opportunity. And we're in the process of following families out now. I will give you some of our findings. Our findings are in 3 different domains. One is in increased, these are our published findings, in enhancements in reading, play, talking, and teaching. That's both using a survey measure that we've developed called the STEMQ, and we recently revalidated, and it's up online for anybody who wants to use it. We were able to show reductions in screen time a little bit, which is pretty cool because it's like usually we think of screen time as kind of crowding out good things like reading and playing. But here we were able to show that reading and playing actually crowded out a little bit of the screen time. So that was kind of cool. And we showed some reductions in physical punishment, which was not part of the program at all. We showed enhancement in psychosocial functioning, and I'm going to talk a little bit about this in a second, including some reductions in maternal depressive symptoms and some reductions in parenting stress. And then we've shown enhancements in development, including some enhancements in language and cognition, but our strongest findings actually turn out to be in social emotional development, and I will show those to you shortly. So, parent-child interactions. This is just kind of one example, but this is an example of when we were doing the 0 to 3 component, 18 months after completion of the 0 to 3 component on an observational measure where we video recorded and coded words that were said between the parent and child, we were able to see enhancements in maternal utterances, number of different words. That was kind of interesting. The second part of this was the psychosocial part, and this is really interesting because, again, we're not actually looking to prevent or treat parenting stress, for example, and yet we showed some reductions in parenting stress in the parent-child relationship. I'm going to show you what I think that's about in a minute. We'll return to this. And then we saw reductions in maternal depressive symptoms. We are not treating maternal depression here in any way, shape, or form. What we are doing is helping families to feel a little bit better in the context of the stresses that every family feels around being a parent, but low-income families feel even more. Then I'd like to talk a little bit about social emotional development. Here for the 0 to 3 program, we had around a 0.4 standard deviation in reduction in hyperactive behavior a year and a half after program completion. When we looked at it by sort of meeting category of clinical hyperactivity, we actually found that clinical level hyperactivity was reduced, and reduced in a fairly substantial way. Among families at the highest psychosocial risk, it was reduced from 16% and almost entirely went away. In epidemiologic terms, one can talk about something called the number needed to treat. And the idea here is that if you were to give VIP in principle to 6 families, you would have one of them where you had a reduced case of clinical level hyperactivity. So this has large implications for cost-benefit analyses, which we have not done. Next, we'll mention that when you add a 3 to 5 component to the 0 to 3 component, we had additive impacts. And then last but not least, this is coolest. The author of this paper is right there. That's my close colleague and friend, Adriana Weissletter at Northwestern. So you can all go and talk to her and work with her. But the what she was able to show is a pathway leading from reading aloud and play to changes in the parent-child relationship, reductions in stress about the parent-child relationship, leading to a reduction in behavior problems. This is a really neat idea with implications for a lot of the work that a lot of us are doing. When we read and play with our children, not a big surprise, but there it is. We enhance the parent-child relationship, and that leads to changes in social and emotional development. So look for it. It's not published yet, but any day. Next, it is under review. Okay. I want to finish with talking about. I want to spend my last 5 minutes talking about preparing for our work preparing for scaling. So we did this in the context of RCTs first, which is probably the backwards way to do things, really, if you think about it from an implementation perspective. And having done this work, eventually we began to think about, are there ways that we could scale and implement this? And we've spent the last 4 or 5 years now working on preparing for scaling and ultimately beginning some significant implementation. That work included fully manualizing the program, developing a training course, designing materials to support fidelity. And now I'm glad I used that word because we're not measuring it yet. I think we'll have to wait another 20 years to measure fidelity based on what I just learned. And then we developed a VIP Center of Excellence to support implementation with a nonprofit business plan and organizational structure. And we were lucky enough to have a foundation that really kind of steered us in this particular direction. So the most helpful thing that was done. In terms of scaling, I was thinking about this. We've done some exponential scaling, which doesn't get you that far when you start with 1. but we've gone from 1 to 2 to this past year to 4 to the upcoming year actually to 8, and we may even double to 16 the year after. Currently, we're at a couple of different sites in New York City. We have a number of sites where implementation is in progress, including at and then in addition, nationally, we've done implementation in Pittsburgh, and we've done implementation in Flint, Michigan. Okay, so I'm going to conclude by talking about the need for linking across and working across platforms and disciplines, and to give you some examples of some of the work that we've had the opportunity to be involved in. One of them is Smart Beginnings in New York City and Pittsburgh, where we link Reach Out and Read and VIP to a McVie home visiting program, Family Checkup, for families at highest risk. The second is Cities First Readers, a New York City Council initiative, linking Reach Out and Read and VIP to libraries and to home visiting. And third, links in progress that we're working on, linking Reach Out and Read and VIP to Healthy Steps at the Family Health Centers at NYU Langone in Brooklyn. You'll notice that one of the themes here is the link between Reach Out and Read and VIP, and then thinking further of the way in which we link to additional programs. Okay, so I want to mention Smart Beginnings briefly. I have like a minute. How many minutes do I have? I have 1 minute. Okay, so what I want to mention is that this is a really cool model. It's a tiered model linking primary prevention through Reach Out and Read and VIP, and then to secondary and tertiary prevention for families who screen positive for relational health difficulties on the basis of an annual screen, who then receive Family Checkup, a more therapeutic model delivered by a social worker. And we are doing this as part of a 2-site randomized controlled trial in New York City and Pittsburgh, which is NICHD funded, and it's with there are 3 PIs, myself, Danny Shaw, and Pamela Morris. What I will say is that our findings to date are primarily around engagement in parenting, and we are seeing some preliminary findings in that direction, but that's just en route. And then I want to mention something else, which is that it looks like the Smart Beginnings VIP Family Checkup linkage is going to have a large citywide initiative in Pittsburgh, where potentially a birth cohort of 5,000 children, together with a preschool cohort of around 3,000 children, might be eligible for the 0 to 3 and 3 to 5 components separately, and we will see. We will see what happens. Certainly not all of those families will receive those programs, but we are going to learn a lot about what population level implementation means. Last but not least, or almost last, I want to mention that, and hopefully not least, I'll mention this New York City Council Cities First Readers program. What's neat about this is the idea that this actually came from the New York City Council. They've brought it from a $1 million program to a $5 million program, and it's linking across primary care with the whole library system and community supports. So there's a lot of work to be done on this model, but it is not only cool, but it is also part of the Bridging the Word Gap Research Network, and there you have it. And then I'll just mention that we are working directly now on linking Healthy Steps, Reach Out and Read, and VIP, and community level services directly right now at one of our implementation sites in Brooklyn, and hope to be able to have that in progress soon. But it's really interesting to think about how those models work together, and I think that would be a great topic for conversation during the next hour. My final slide is the policy implications, which are that we need primary prevention beginning in early childhood, very early childhood, that positive parenting and relational health are critical targets for interventions, and that pediatric primary care can complement home visiting as a population scalable platform for promotion of parenting and school readiness. If you're interested in hearing more about Video Interaction Project, go to our site, and you can see videos about it, and I want to thank our many funders and collaborators. Thank you.
Any questions?
Great talk, Alan. Quick question. You mentioned the collaboration of VIP and Reach Out and Read, and now Healthy Steps. Are you all looking to one or a number of them to be sort of the platform from which others can layer on? I mean, there's such opportunity. When I think about the 6,000 Reach Out and Read sites, I think, oh my, the platform for reaching many, many families is there.
So the answer is definitely. And I think that the key to making these kinds of efforts work is to understand how to link across different platforms. And there are no two ways about it that both Healthy Steps and Reach Out and Read individually or alone can serve as that platform. What is really amazing at this moment about Reach Out and Read is that Reach Out and Read brings more than 6,000 sites and more than 30,000 trained pediatricians who are actually already have bought in this idea and can support not only Reach Out and Read, but are also really enthusiastic and interested in thinking about how to do as much as they possibly can together with a implementation infrastructure formed by the Reach Out and Read National Center.
I just have a quick question, which is, I know that NICHD is clearly a strong funder of your research. Where else are you getting support for that research?
So I'm sorry, I ran out of time. I did. That was perfect. So we've received funding from foundations and from governmental entities. So there are a number of foundations that have given us funding, including Tiger Foundation, Mark's Family Foundation, Gutman Foundation, and a couple of others. From New York City, interestingly. New York City has a lot of different initiatives happening, and actually two different initiatives have funded VIP. One of them is the New York City Council. VIP is one of now 13 partner programs within that initiative and is helping us to expand. The other is New York City Department of Health and Mental Hygiene, which is in funding and expansion to Elmhurst Hospital, and with a goal, like the City Council, of thinking about ways to bring it across the city.
While you guys get up, Dayna and Amanda, we are going to we're getting younger and younger programs here. So started with Reach Out and Read, moved to VIP, and now to Oakland Promise's Brilliant Baby Program, which is, I believe, in its about second year of implementation. So, and so we're going to have a team to present this one, the person who developed the program outside the healthcare sector, and then the partner, Dayna Long from the Oakland Children's Hospital, who embraced it and is implementing it through the healthcare system. So
Thank you. My pediatrician says we all need to stand up.
Stretch.
Stretch.
Everyone
Stand up, just
Arms
a few
up.
steps.
Twist around. Oh.
A little bit of motion.
Appreciate it.
All right, let's get settled again.
Thank you so much.
Yeah.
So Dayna and I are going to tag team, as Marc said. My name's Amanda Feinstein, and I'm the director of the Brilliant Baby program. What we're going to do in our time is I'm going to first explain what Brilliant Baby is and how it works, and the research that we looked at to initiate this program. Then Dayna's going to talk about Children's Hospital, the Claremont Clinic, the work that they do to support addressing social determinants of health, and why that was, when we approached Children's Hospital, it was like, well, of course, we're already in your lane. Then we're going to explain the randomized control trial that we are undertaking, and we're in the early stages of that, and share some of our lessons and questions about moving forward. So, without further ado. So I just hit what? Just hit the wrong thing, is what I just hit. Great. So one of the things that's critical to know about Brilliant Baby is this is part of a larger initiative in the city of Oakland that is really about preparing our children, our children to graduate high school with the expectations, skills, and resources to complete college and be successful in a career of their choice. That's our mission statement. And this initiative, which is called the Oakland Promise, is really spearheaded by our mayor and the superintendent of schools and 100, literally, institutional partners that are all honing in on how we prepare our kids for success. And we are doing that in a number of ways across the cradle to career continuum. Brilliant Baby is the early childhood development piece, and I'm going to talk most about that. But after our children grow up and land in elementary school, we also have a program called Kindergarten to College. And it's deep work with the school district to promote a college-going culture, to build in our youngest students a college-bound identity, and to begin providing scholarships and encouraging parents to save for their kids' education. In middle and high school, we are partnering again deeply with the school district to build out college and career centers called Future Centers, where we're helping children and families understand, helping kids in particular think about their career path, think about college, apply for scholarships, and build that infrastructure. And then our third part of this fourth part is actually providing scholarships and college completion and persistence to support to low-income students that graduate from high school. Currently in Oakland, 15% of our ninth graders go on to graduate college within 5 years. And that is a travesty that has sort of galvanized our leadership, civic, as well as business, as well as educational, as well as early childhood to kind of build this initiative. So it's programs, but it's also really a movement in our city to change the trajectory for our kids. There we go. Back one. So why Brilliant Baby? Why start with infants in this larger vision? We are honing in with a deeper level of support for low-income families that is really about helping parents prepare their kids for school and optimal health and early development. Our focus is to cultivate optimism and a focus on baby's academic future and set an expectation for college from birth. That's one of the core things we're trying to do. So it's about influencing the way parents think about their kids and engage with their kids around that. We're also looking at ways to provide emotional support and practical support around financial stress. Because financial stress, as we've been discussing all day, is a huge variable in undermining both parent kind of well-being and bandwidth, as well as a distraction from the attention that parents would like to give to their children. So we have an intervention that's focused on reducing financial stress. And lastly, the intervention is about reducing isolation and building a sense of community that is kind of based on this common shared focus on children's academic success and improving financial well-being. And we're targeting this intervention specifically at low-income families in our community. So parts of the Oakland Promise are universal. This piece is honing in on support low-income families, Medi-Cal eligible, living in Oakland, and connecting with families when their baby is under 1 year old, and for our study, under 9 months old. Okay, so what do we offer? What is this program? The first thing we do is establish a 529 college savings account for the babies. So probably many of us in this room have, for our own children or grandchildren, or for ourselves, a 529 college savings account. It's a tax advantage savings account that virtually no low-income person knows about in our community. But what our program does is it offers parents the opportunity to open this account and put $500 in it. And that $500 is invested, and we choose to put it in an age-based, moderate-risk investment vehicle in that child's name and with that child's Social Security number for the duration, the next 18 years, and then they can use it for their education. $500 is a meaningful amount to parents. We focus grouped this. It's an aha moment when your baby gets $500. And we know that when you look at sort of the price of college later, it's a drop in the bucket. But that isn't actually what matters to our families. What matters to our families is that they have an investment vehicle for their child now, and their baby's going to college. And so that's the core of the program, the first component. The second component is that we offer the parents an opportunity to work one-on-one with a financial coach. And that financial coach is someone who connects at a personal level with each parent and helps them sort through what they want for their families in terms of financial goals and what the path they will take to get there, connects them to practical resources, provides knowledge and coaching and encouragement, and is also sort of an accountability partner. So if I say I really want to have $200 in an emergency account for myself, then we're going to have a conversation about how you're going to make that happen. And they've got all kinds of fun tips and ways to support. But then I'm also going to text you. How'd it go? You said you were going to drop your change. You break a dollar, you put the change in the vase. How you doing? Is that coming along? So there's a relationship there. And our parents are identifying goals largely around savings, to have an emergency savings, to purchase key things, whether it's tires or books for their kids or whatever. Usually it's a purchase. And starting small businesses and and addressing credit repair. So there are all kinds, but the key is it's driven by parents, and it's about improving their sense of financial well-being. While parents are in that coaching program, which is not a requirement to get the baby's account, by the way, it's totally optional, and about 60% of our parents choose to participate, they get a stipend of $100 for each of the first 3 months they're working with their coach, just directly into their personal savings, actually into their PayPal account. And they have the opportunity to have a savings match of up to $200, again, matching their personal savings. So people are financially stressed, working with a coach, and they have both resources and an ally to move forward. And what we are seeing is that it does make parents feel more secure and optimistic, and that gives them greater bandwidth to focus on their little one. And the third piece is the partnerships and community. The lovely woman in the middle is our mayor. This is, again, very much a civic movement, this Oakland Promise. And we do lots of nice things, like have an annual event that all of our families are invited to. It's a celebration at Children's Fairyland. You can kind of imagine what Children's Fairyland is. It's a very lovely place for children and families to gather. We have peer support groups around financial issues. We have a family leadership group. And we have lots of partners, which I'm about to show you. So how do families learn about this? Our medical partnership is one of the pathways, but essentially Brilliant Baby is being embedded in the infant home visiting programs operated by our county public health. It is an offering by our Oakland Early Head Start programs, a couple of our nonprofits, and significantly UCSF Benioff Children's Hospital at the Claremont Clinic. And we're going to talk a lot more about that in just a sec. But we also have a whole bunch of other partners. The larger vision here is to leverage access and support and resources for our family across lots of different institutional players in our community. That gives you a sense of that. Oh, shoot. So we are in the installation and initial implementation phase, going back to Allison's analysis. The Brilliant Baby program has been in operation just about over a year. We have 320 babies who have been enrolled by our implementing partners. We train the staff in all these organizations about how to explain this program, how to go online and literally sign each child up for a college account, and how to help parents understand what this coaching opportunity is, which then my staff follows up with and delivers. So each of those babies has $500. That's $160,000 already invested for these children's futures. Families have an asset in the market. If, for example, markets are, growth is not a given, but if those dollars grow at 8% average, that's $2,000 18 years from now, a little bit less when you take out, kind of inflation, et cetera, but it's money in the market. Again, 62% of our parents are engaged in coaching, and more than half have completed 3 or more sessions so far. We take a baseline survey of everybody that's in the program, and 80% of parents say they expect their child to complete college when they sign up. 68% of parents indicate concerns that the money they have won't last, which is to say they are under some financial stress. And 58% feel like their finances kind of control their lives. And what we will do in a year from now, we ask parents the same questions 1 year later. We're just starting to do that, so I don't have the results, as well as questions about their experience of the program. But I think we will be able to know for our entire universe, all 320 now. We enroll another 5 babies a week. We're trying to get to 10 babies a week. We want to have 1,500 babies in this program during the 3-year demonstration phase. So we're really just starting. Darn, I keep hitting that wrong button, don't I? Go for it.
You have a clicker
It's
right here.
easier, yeah. So the next slide is actually just one that is a nice backdrop for sharing some of the things that our parents are saying. We don't have our video together yet, but we have done a lot of interviews. So I just want to share a few quotes from some of our parents about how they feel about having the account. So this parent says, getting the financial statement for the 529, and our partner is called My 529, used to be the Utah Educational Savings Plan. Getting financial statements in the mail is a relief. There's actual money for my son. I'm able to see that there's money for him set aside, and I'm not just told that. I can actually see it. I see money for his future. Another parent said, I think for low-income mothers, it's definitely the way to go, as in being part of Brilliant Baby. A lot of the moms may not have had anybody in their family go to college. They're not thinking in terms of that, but this does make it possible. Another parent said, it makes me happy to see the statement, and that makes me very positive. That was important because sometimes I don't see that much money in my own account. And I already have $500 in my son's account. And then this is a statement from one of the parents talking about her experience with financial coaching. The financial coaching is wonderful because I need to definitely get my finances in order. So that program has already helped me in many ways. I set a goal to get my credit together and get out of debt. I started accomplishing some of those goals with my financial coach. I actually have already started paying off my debt. I found out how to get some of that stuff off my credit and help me increase my score. And the money that you provided to complete the program, that $100 a month stipend I was mentioning, it actually helped me pay off some of that debt. So it was wonderful. It means a lot because we want to buy a house. Credit is important. Credit is important. So he'll be starting the program next. She's pointing to her husband, who actually had not done the financial coaching and who then did the financial coaching. Side note, a lot of starting with mom in the coaching and dad joins because it's really helpful to address financial stressors as a unit. Oh, and then we have, looks like things disappeared up there. Well, the parts that are missing are the things you all have been talking about in terms of the impact of stress on parents and parenting. But these last 3 bullets are kind of some of the key research findings from the asset building field, which is kind of converging here with the health field and the early child development field in our initiative. And one key point is that having a college savings account from birth was shown in the only randomized control trial in the asset building field that we already have, which is called SEED Oklahoma, to improve the social emotional development of babies and to reduce maternal depression. This is a study that was done, again, in Oklahoma on the children are now 11 years old. That data was taken when they were 4 years old. It's also been shown that children, low-income children with a college savings account in their name, just having that in their name and being aware of it, are more likely to enroll, 3 times more likely to enroll in college, 4 times more likely to complete. And lastly, the Consumer Financial Protection Bureau recently did a study of financial coaching and was able to kind of document how participants' not only sense of economic well-being, but also material well-being was advanced through that kind of a strategy. So that's the context of Brilliant Baby.
So at this point, this is where we were talking yesterday about having systems collide. And I want to walk you through a day in my life as a pediatrician. So I want to introduce you to some of my families, because for those of us that work in federally qualified health centers, we feel as if we're in the front lines of the battle of poverty every single day. So this particular family was a family that I saw who came into clinic, one of 12 families of my morning. And as infants, these children were born, they had substances in their system. They were given to a mother to care for who had just lost her son. Her son had been murdered in Oakland the previous year. They had horrible asthma, allergies, eczema, were very difficult to console. And we had to refer them not only to the pulmonologists and the skin doctors, but also to our behavioral health therapists. When you work in a clinic where 90% of your families are folks of color and 98% live at the poverty level, there is no way that we can get through our day with 15-minute visits. Starting about 8 years ago, we began to think, how are we as a healthcare system, as a university, systemically asking questions about determinants of health? What questions are we asking? What modalities are we using? Which led to us doing a randomized trial around issues of food insecurity, housing instability, concerns about mental health, discrimination amongst our families. And what we found was that the numbers that families were reporting were extraordinarily high. Almost 60% of our families were endorsing food insecurity. Almost half of our families were concerned about the mental health of the primary caregivers. Almost half were concerned about housing, and just sort of making it through every single day. This led us to another trial where we started to think, how can we, in the most low-cost manner possible, start to screen using technology and community health workers in order to help to resolve needs and improve child health. We randomized over 2,000 families, and again, the needs of our communities were amazingly high around food insecurity, housing instability, the ability just to keep the lights on. And we paired families with community health workers who spoke the same languages, came from the community, have walked in our family's shoes. And what we proved in a statistically significant fashion is that when families work with community health workers, 1, you can actually resolve unmet needs. When you resolve unmet needs, you improve health outcomes. 3, we had high patient satisfaction rates, and there's a huge gap in the quality of our care because less than 17% of our families reported that they'd ever been asked these questions before. We also started looking into adverse childhood experiences around abuse, neglect, and household dysfunction with the acknowledgement that the national data doesn't reflect low-income communities and communities that often are poor. And so although the national data suggests that about 60% of our population experiences one adversity, upwards of 90% of our families had experienced at least one. And we know that for kids that have 4 or more adverse childhood experiences, there's a 32 times more likely chance that they're going to have learning and behavioral issues. So we've been creating systems, including a technology called FineConnect, that improved our capacity as a system to really holistically address these determinants of health. The system has a number of features, including integrating with the EMR, having customized algorithms, being able to run on any desktop, laptop, or tablet, and provide sophisticated geolocated real-time resource matching and action plans. We created a suite of tools, we call them opportunities, where we use evidence-based questionnaires around food insecurity, housing instability, child mental health, adult mental health, and development, that in partnership with community health workers, we create these action plans that are then connected to our electronic medical record and have a really robust knowledge base of community resources. It allows for scalability and outcome tracking as well as for QI, and it comes with the ability to integrate into different clinic flows. So this was our milieu when we were approached by the mayor and the city to say, hey, how can we actually look on a population level and galvanize an entire population of Medicaid-eligible children out of poverty? And it's truly transformative to be able to walk into a room during a well-child check, absolutely give a book, say that your baby is beautiful and your baby is going to college. So we decided to study this in, again, the most rigorous fashion that we know, with a randomized control design with our partners at the University of Chicago and NORC. We wanted to make sure that we could isolate the effects of each component. So knowing that our underlying standard of care is really to holistically pair families with navigators and technology to address unmet basic needs, development, and mental health, we then had a control group. We have one group that gets a college savings account and another group that gets a college savings account as well as the financial coaching, so that we can look at all the variables so we can actually say, well, what works? And I don't see Jocelyn in the audience, but when she talked about the need for rigor and to transform pediatric practice, I think we're actually doing it right here. There's a number of different outcomes that we're looking at, and ultimately our question is, what impact will the combination of college savings accounts and financial coaching have on the pediatric medical home in terms of influencing both caregiver and child well-being? Our outcomes are about financial well-being and expectation for college-bound futures. It's very different to want your baby to go to college compared to knowing that you have the resources to make that happen. And then we are studying, how does this impact child health? How does that knowledge that my city, my doctor, my community believes in me and that this is my future path, all I have to do is get there. We're looking at child development, diagnoses, utilization, as well as kindergarten readiness. We've learned a ton of lessons in working together. And I have to say that for a pediatrician, this research was community directed from the very beginning, right? It was the mayor's office and it was our community partners that came to us in combination with the University of Chicago to say, how can we actually truly do population health in a way that is transformative across our sectors? It took a ton of time.
Yes.
In terms of getting all the legal agreements and the MOUs, writing the IRBs. We had to work out the interoperability of our technology systems, whether it's FineConnect or we use a research database, which many of you know, Qualtrics, some of you guys use RedCap. We also use a Salesforce platform for the for the Brilliant Baby program. We had to figure out how are we using these community health workers to do the recruitment and the consenting and making sure that we're giving the warm handoff to our program. We're working on models where we're actually trying to embed the financial coach within the medical home so that we can make appointments for financial coaching at the same time as families are coming in for their well visits. We've been thinking a lot about sustainability and scale, and we think we have something really great, and how are we going to work with you guys in order to scale this to all of these 6,000 pediatric practices? A lot of it has depended on the political will. Luckily, we have a fantastic mayor as well as assembly. And we really needed to make sure that we had their buy-in and support, and so that we can have the leadership of the hospital along with the mayor working together on this. And the process has been really iterative. We've allowed each other to fail and to make mistakes and then to put our head together and say, well, how are we going to make this better?
Thank you. Yeah. That is us. We're happy to answer questions.
You had 2 questions.
We'll do one question and then hand it over to Marc.
I just had a question. You referenced, Hi, I'm Raquel Jeffers from the Nicholson Foundation.
I just had a question. You referenced in the literature from the asset building community. I was wondering if you could talk a little bit about the difference of your approach from just a regular old individual development account in IDA, right? So there's been a long movement to set up savings accounts for education or home ownership for low-income families for a while and match those funds. And I just wanted for you to talk a little bit about what it means to connect it with the birth of a child and how that's different from the normal
Sure.
IDA movement.
Sure. So the notion of making a child's college account a core asset strategy for families really emerges out of the last 20 years of experimentation, programming, and research about supporting low-income families to save. I mean, the inclination would be, oh, families don't have money, they're not going to save money. But in fact, there have been projects all over the country that have identified that with support, information, and often a match, families do prioritize building savings. With children's savings accounts for college, we have really kind of honed in on a particular purpose for savings. But in our financial coaching program, we're kind of savings agnostic, because it's really about whatever the family needs to do to improve their financial well-being, and they're going to sort that out and articulate that in the context of coaching. And often it's to save money, and at this point it's seldom to save money for my baby's education, because really our families are looking at much more pressing needs like paying the PG&E bill and fixing the tires and much more practical things like that. But it is kind of a whole. And the whole notion and reality of having a financial cushion and the psychological effects of the existence of that cushion and the practical effects of having money that you can access either in emergency or over time for your child's education is a really important factor in preventing families who are on the margins of stability from dipping into a financial crisis. So our program is really integrating both types of assets and is emerging from research from the asset building field, the child development field, two-generation anti-poverty work, and also the health sector. So it's a little bit of it's a meetup of a lot of different ideas that impact and realities that impact families.
Okay, okay, come join us again. Thank you. So we thought we wanted to be as interactive as possible, and you guys have all been very attentive so far and interactive. So what we thought we would do, I have 5 questions that I'd like to ask the panelists. But we might not get to all of them, because if you guys get really interested in one of these topics, what we're going to do is we're going to ask a question. The panelists are going to have a minute or 2 to answer that question, and then we're going to open it up to all of you. So we'll have a discussion about that topic that they'll be discussing, and then we'll move on. So we'll try to get to all 5, but if we only get to 3 or 4, that's all right. Okay. So I'm going to start. I'll just go down down the line this way. Okay, Alan, if you don't mind being the first. And so the first question was, what are the major implementation or scaling issues facing your program, and how are they being addressed?
Do I need to turn this on, or you hear me? You hear me? Okay. So I would say that there are 2 major issues. I mean, besides the obvious, which is sort of funding generally. One of the implementation issues is sort of thinking about the fact that, even here, we're hearing about at least 2 different domains of primary prevention. And clearly, if we're thinking about implementing in pediatric primary care, there are lots of different issues that we're thinking about if we sort of extend to other presentations this morning and otherwise. It's a lot. You start to throw in needs for significant other issues like obesity prevention or food insecurity, although certainly financial-based interventions may begin to get at that as well. And the question of how to kind of bring this all together using programs that are going to be effective and yet somehow not stepping on each other's toes and making it work is sort of the first thing I wanted to say. The second is that from the perspective of scaling, one of the things that I've gotten to learn recently, and we heard a lot about earlier this morning, is the need for infrastructure to support that scaling. And a core question is how do you actually manage to have sufficient infrastructure to support the scaling that is happening? And it is I think it's probably one of our largest challenges at this moment.
Thank you. Dayna and Amanda.
So we kind of think about scale in a couple different ways. Like our first tier of scale is we want to be able to offer every baby born in Oakland who is Medi-Cal eligible a college savings account and the coaching opportunity for their parents. So that's local scale, and that would be about 2,000 children a year. And so some of the challenges of scale are we're very committed in embedding this resource in the existing infrastructure that serves families. Not about to set up a whole new, hang my shingle, come in, I'll give you, we'll hook your kid up with an account. This is a resource that needs to be invested in our kids through their pediatric home, through their home visiting program with the county, through a number of different places. The logistics of explaining our program, which has both financial and technical components, is a big body of our work. So sort of the training and development of our partners to enroll families with this asset and into the program is a piece. And also just the building the capacity internal to other organizations that love this, want this for their families, but that's not what they were built to do. So there's a growing together element of how we institutionalize and scale and build capacity.
So in terms of how to truly transform the pediatric medical practice, there's definitely a movement that's happening to really focus on the medical home and to move the pediatrician as not the focal point, but the medical home itself is the focal point. And so in terms of the scaling, about having conversations about financial futures and college-bound readiness, in some ways as pediatricians, we're the natural host to that conversation because we already do that, right? We already are so encouraging to our kids. And if anything, this gives actually something tangible for us to do that creates a remarkable moment in the exam room when you actually can say, your baby's going to college. And so that piece of it, that anticipatory guidance piece, I think is going to be really exciting for pediatricians. I think that the much larger issue is what Alan talked about, is how do you build the capacity in the infrastructure? The reason why this marriage worked so well is because we've been working for a long time on this navigator, this community health workforce, which is an essential part of primary care pediatrics. And I think having other staff as part of what we do every day is really important. And I would love for some of our colleagues here from CMS and some of our economists to think about how we're going to move to our medical model that really focuses on community health workers as opposed to the pediatricians delivering services.
I think I'd like to come back to that question of fidelity and scalability, because I agree with everything that's been said, but I'm not going to say it again. So I want to, who here does primary care? Okay, so I hope the people who do primary care will forgive me if I reveal one of our trade secrets, but even within my individual practice, there are days when I feel I do this with verve and style and fidelity to the model, and there are days in which I do it in exactly the way I tell the residents not to, right? So, I mean, I think that one of the things that we at Reach Out and Read, we grew fast because there was federal money for a while, because there was grassroots desire for the program, because how can you say no to people who want to do it? And so for us, there's a real scaling issue of growing is important. It's still important if there are more people who want to do it, but it's much more important to go back to the people whose hearts are in this, who want to do this, and try to get everything we can out of the effort and dedication that they're putting in. But as Rahil said about Healthy Steps, it's sometimes harder to go back to a place that is doing something already and change the way they do it. So I think that for us, that balance, figuring out how to improve fidelity without turning away the people whose hearts are in it and have been in it, and at the same time responding when other people want it. And then second, coming back to what's been said about infrastructure, we have this amazing network, but the network also takes care and attention and nurture and effort. And then finally, just to agree with what's been said before, I mean, I'll say, you sort of said this before, and I actually at lunch was saying to Rahil, you know, Reach Out and Read should be your gateway drug, right? We have a network, we're in more than 6,000 health centers. People say, this is wonderful, but our families need more. We should be saying, you know, let us show you what Reach Out and Read looks like in the context of Healthy Steps, because most of the Healthy Steps sites have Reach Out and Read. So how can we actually build on the structures that we are all trying to create so that we can together do absolutely the best for our families, even on the days when we don't quite meet our own standards?
I'd like to open the floor to the room. So this is about the implementation. You want to follow up with our panelists about implementation and scaling issues.
My name is Uma. I'm an educator who works with children who are deaf or hard of hearing. So I see the impacts of early primary care when I see them in the school, early intervention, preschool. And my question to all of you is, as you are developing these interventions to impact children in low SES settings, is there a plan to address disability as it comes up through the system?
You can start at this end and work back this way. Yeah, we actually, and I'll be glad to show you, we can show you, we've actually done a whole project with, headed by developmental behavioral pediatricians about what does this look like for kids with disabilities, with a whole range of disabilities. How do you think about literacy, language promotion? How do you, what are the special messages? How can we make it work best for these kids? I think that's a really tremendously important constituency, and, you know, really important to think about both including them in the intervention, tailoring the intervention where it needs to be tailored, but also remembering that those underlying messages of, I mean, spending time together, enjoying its stories, everything doesn't have to be therapeutic, right? That they need those same messages of resiliency, routines, and family bonding.
So I think it's quite clear that health disparities and disabilities are worse in kids of color and kids that are low income. If you look at rates of obesity, asthma, diabetes, hypertension, as well as learning issues and mental health issues. And so by providing services, by using technology as a capacity builder to have standard work and to do screening, what we know is that if you have asthma and you don't have enough good food, you don't have access to activity, your asthma is going to get worse. And so by having primary prevention as a universal base, you actually are improving disease outcomes as well.
And I would say in terms of the clinic or any of our partners offering the college account to parents with new babies, it's all parents with all new babies. So there's no, it's inclusive. And one of the advantages of the way we've structured that initial Brilliant Baby College account is the program owns that account, and it's linked to the child through their social security number. So they will not need to be worried about having an asset that would influence SSI later. And so that's a plus. It also is an asset that will not influence asset limits for TANF or food stamps.
I'll just add that one of the, as we've sort of moved from research to implementation, we had sort of moved from, you know, very well defined populations to populations with, you know, in which almost any challenge might be present. And so, you know, one thing that we have now therefore started to do was to be able to think about, you know, what does it mean to take, in this case, Video Interaction Project, and move it to families with special needs of one of a number of types. We've, you know, as Perri said, you know, the kinds of messages that, you know, that are being delivered by, you know, programs supporting parenting around book reading and play, certainly those messages are going to resonate and be important regardless of the specific special needs that families are facing. And yet, at the same time, the way in which programs are delivered on the one hand and the research base for them is different for each of those populations. So right now, we've developed and have piloted with a limited number of families adaptations for children with disabilities, parents of children of preterm infants, and for that matter, thinking about issues around foster care, both biologic and foster parents, and we're doing that at Children's Aid in New York. I think that there's, the one thing that's clear is that the messages resonate. I think that research will need to be done for all such programs to understand how to maximize their impact.
We'll take one more and then we'll move back to you. Please, go ahead. Yeah.
My name is Smina, and I currently am a researcher at Erickson Institute. And we're doing a study in which we're looking at children with lead contamination. And we're looking at whether early interventions can help prevent delays and even stop cognitive delays. But it's really challenging, especially with lead contamination, that you might not see the delays until much later. And how do you convince professionals that to be proactive by going through all of these interventions earlier on to prevent something that's going to happen much later? And then the argument is, if a child has 18% cognitive delay, how many interventions are needed and what kinds? And we're kind of caught in that challenging situation.
So I think that the solution to that is that you actually need to look at how that lead exposure is impacting utilization of the healthcare system, missed days from school, and also look at the types of special education services that are required, whether it's through needing an IEP or special resource classrooms, and to try to get the dollar amount of that versus how much does it cost to actually do the prevention.
Yeah, and I'll just, I guess the one thing that I might add is that, from the perspective of, thinking about, children with significant biological risks, including lead poisoning, I think that there is at least some good data to support the idea that either in the context of significant biological risks as well as in the context of significant psychosocial risks, that supporting the parent-child relationship can have beneficial impacts.
Thank you. I'm going to start down here with you, Perri, and ask the next question. We'll come this way down the panel, which is, and I know that some of the programs here are more mature in terms of their evidence base. I'm going to start with you, have the biggest evidence base. But the question is, through the evidence that your program has gathered to date, do we know what works for whom and under what conditions in your program?
So that's a great question. And I might actually ask Alan to speak a little bit to it about Reach Out and Read as well, but it's a great question because we know, and the answer is, as always with research, we know some things, but further research is needed. I'm sure that will come as a great shock. We have had some studies that tried to look at the different components of the program. The anticipatory guidance component, the book component, and found that the anticipatory guidance was the single most important key. Most of the research has been with children who were, I think all the research has been with children who are socioeconomically at risk. Some particular populations have been looked at. There is research in Spanish-speaking low-income populations, and also interestingly, there's one study that was done in non-English speaking populations for whom we did not have books in the correct language. Going back to a comment that somebody made, populations where, I think it was Somali and Hmong kids coming in and we just didn't have the books, and showing that even in populations where, for all of our best efforts, we could not give them the appropriate language, parents still liked having the books, still reported increased. So the answer, the answer is we've got some information about some special populations. I think we would all like more information about the different ways, what is the most effective way to deliver the program, and what are best practices. And I think we'd all like more information about children who are not socioeconomically at risk and what effect this has there as well. Alan, you want to?
I'm going to jump to Alan, since you
just with Reach Out and Read, you want to?
Sure. So the first thing that I want to highlight is that, and in my talk, I highlighted the importance of the book or the toy as a prop, but the other part that I totally meant to highlight was the importance of the relationship. And I think that that's a core element that is necessary, not necessarily sufficient, for interventions to be effective, and something that should not be forgotten about. So in the case of Reach Out and Read, the relationship with the provider, with the trusted provider, I think is an absolutely critical part of this. The information is not coming out of the sky. And I sort of say that because much as I think that modalities like text messaging and things like this are really potentially very useful, but I think I view them as kind of adjuncts to, and supplementary to the relationship-based approach that Reach Out and Read has embodied. The same is true for VIP. VIP is also based upon a relationship that happens at each well-child visit with a bachelor's level person who. And it is through that trusted relationship that takes place. But I don't think anything can replace the trust that's going to come from the provider. I want to mention a couple of other things in terms of Reach Out and Read. Reach Out and Read's applicability is incredibly wide. And one of the reasons that we can say that is because there have been so many different studies in so many different populations. That's one of the reasons why I made the claim that I did, that it was the most studied evidence-based program that is presently out there. We'll mention that over time and currently, those populations are being extended, so that we now in fact have data that beginning anticipatory guidance and provision of books, with the extension of Reach Out and Read to birth, does have impacts. And so that's just something to bear in mind. In terms of, I'll mention one other thing, which is that I've recently no, I won't go there, but I will say that the data on sort of what works for whom in different at-risk populations across studies, to my mind, is fairly mixed. You find data around programs like this, VIP, home visiting programs, other programs, where you see the strongest effects in the highest risk groups. And then you see other studies where the highest effects are really not in, are really in maybe slightly less risky groups. And so I don't know that it is clear cut in terms of what works for whom under what circumstance. And I think, as Perri said, more research is needed.
Amanda and Dayna, so your program is so new. I mean, I know about your evidence base. So maybe you want to talk about the evidence base that informed the work that you did. Yeah,
I think that's right. So Brilliant Baby kind of builds on the shoulders of other programs that come before us. There are 35 plus college savings account initiatives around the country. There's 50,000 kids who have college savings accounts through these programs. And then there's years of research, a lot of it led by the Center on Assets, Education, and Inclusion at the University of Michigan, used to be University of Kansas, and Washington University, the Center for Social Development. But the kinds of things that we know, and particularly important to me from this randomized controlled trial in Oklahoma, children with $1,000 account from birth, but no other intervention around it. All 1,200 kids scattered around the state of Oklahoma. We have seen that the social emotional development indicators were higher for the children with the accounts, and digging more deeply, it had mostly to do with how the parents felt about having that college account for their child, and how they then interacted with their children. And also indicated a little bit of a reduction in maternal depression, just from that one RCT. So part of the reason we're going through, frankly, the heartache doing RCT. This is not the crowd who needs to hear that, but it's a very complicated endeavor, and that's not what we're not academics. These are my academics. But we feel like it's so worth it because we really need to know, and we need to repeat that kind of an outcome to know if and document the impact on children and children development and family wealth accumulation. Some of the other really important kind of findings in the college savings account field is that this notion of saliency, of kids thinking about themselves as people who go to college, and that having an account in your name and having a family that talks about and puts whatever kind of money that goes in there builds that saliency and that that identity as someone who does achieve in this way. And it also, there's Dr. Willie Elliott talks about normalizing difficulty associated with going to college. So yes, it's going to be expensive. Yes, you got to work really hard in school, but that's what we do because that's what we as a family and we as a community expect of our kids. And that's a whole different conversation than if your kid and your family is just feeling like that's for others. We can't go there. So that's some of the research that inspires us, and we intend to add to that knowledge base.
So when I think about answering that question is, how do we know what's effective or what works or where's the evidence base? I actually think about it from a biologic perspective and what are the social and environmental factors that we know cause biologic disruption, particularly in our neuroendocrine systems. And so we went through this process where we looked at different types of trauma that affect kids, whether it's abuse, neglect, or household dysfunction, and where was the evidence that linked to biologic disruption that actually affect cortisol or help to stimulate an immune response that ultimately led to poor health outcomes. And although that literature is there for adverse childhood experiences, we really had to look hard for the literature around determinants of health and found that of all the determinants, housing insecurity, food instability, low family cohesion, and discrimination are actually tied to biologic disruption in terms of long-term consequences. And so we pulled together the best evidence-based tools, and we actually developed a biorepository of about 550 low-income kids to look at all of their immune markers, their genetic markers, neuroendocrine markers, and cardiovascular markers. And we plan on following these kids longitudinally to sort of have the first biologic repository in a Framingham study for determinants of health.
Did you want to add something?
I just want to add one thing, well, partially building on this, which is that, you know, what is so critically important, we actually heard about it, I think, in the implementation talk, but earlier is understanding, you know, why is it that we're doing what we're doing for whom we're doing it with, and I want to bring that to the next step, and the next step in that is you know, understanding what is the mechanism of action in the population, you know, with the specific risks that you're interested in. And so I have two things to say about that. One is that as we continue to develop and refine models, I think that the core is to step back, even if we've been working on something for a while, is to step back and try to say, well, you know, why is it, you know, what is the pathway? What's the mechanism by which what we're doing might work? And the second thing that I want to say is that this also raises why it is so critically important, you know, like you guys, you know, able to, you know, sort of be working across disciplines, because no one of our disciplines really has all of the answers.
We are running low on time, but I want to open up the conversation on this topic. Right. Scott.
Thanks. Hi, I'm Scott McConnell from the University of Minnesota, and I actually think I want to make a comment more than ask a question. Okay. This is a really important conversation across the day. I think what we're trying to do is figure out how to raise the bar for more kids. I think there's a little bit of danger, though, in us overreaching and thinking that we have an evidence-based practice and therefore problem solved. Mm-hmm. That, in fact, I go back to Alan's point about for whom. In some instances, powerful interventions are going to be great for almost all kids. In other instances, they aren't. And I think we have to be ready for knowing that we're moving forward, but we still are going to have a long, long ways to go. So we have to congratulate ourselves and then get back to work.
Can we respond?
Yeah.
So I think that point is really, really critically important, and it sort of goes back to this idea of understanding, you know, what it is we actually think we are doing. And I said this to somebody last night, but I mean, it was, you know, it is likely that no one of the programs or approaches that are being discussed is going to, necessarily completely change outcomes across health, education, and life. That would be the definition of overreach, and yet somehow that is the thing that is often, asked and or expected of, these kinds of programs. We're not only not acting in a vacuum with regards to each other, but we're not acting in a vacuum with regards to social determinants of health, which we can only partially do something about, maybe, as well as, education, whether we're talking about, preschool or otherwise, and, sort of broader community factors. So each of what we do has the potential to do something really important, and yet it is going to be, the collective impact that's really, I think, the ultimate goal.
Perri.
And I would just like to make a somewhat heretical comment, which is that this is not only about outcomes. If the various programs that we're talking about are changing the texture of daily life for especially for families who are taking care of children in adverse circumstances, if they are making daily life more pleasant, if they are, you're doing something for your community, you're making the world a better place, you're bringing, brightness, language, happiness into a lot of homes, it would be wonderful, and I believe it will in many ways change some of the long-term outcomes. But, as with, say, I don't know, feeding people who are hungry, or, if I can prove that keeping people warm in the winter actually changes their long-term outcomes, but at least they're warmer during the day, we've done something good. So I think one of the things to pay attention to in these programs which address parent-child, family interaction, and leave people feeling better is that there's also a lot. I don't know. When you go to sleep in your warm bed, you want to know that everybody in town has heat. You want to know that children have food. I want to know that they had a book at bedtime. So that's all. There's another kind of not overreaching in which we also look at the everyday texture of people's lives and how we might be trying to make things better.
I would love to ask one more question of this panel because I'm really curious about this, and I have 5 minutes left, I'm being told. So, and we're going to have a break after this, right? And you guys can come and talk to the panelists afterwards. So let me ask you this one, and we'll start in the middle since you guys haven't started yet, which is what types of policy changes would you like to see that will help you and others implement or embed interventions into the existing healthcare setting?
So I love that question because I just got a really exciting email today. And so I'm obviously from UCSF in California, and we've been working really hard with our state legislator in order to pass policy mandates that draw down CPT billing codes for the work that we do. And so we have an assembly member who passed the legislation that enforces trauma screening for kids with Medi-Cal in the state of California. And I found out today that they're actually endorsing one of the prospective pediatric screening tools that we created. And so that felt like a huge win, to be able to use our data to recommend a tool to the state that the state is now mandating as one of 3 options that all providers that see Medi-Cal kids in California are going to recommend. And they're actually going to give Medicaid clinics a CPT code so they can actually bill for it and document that they use the screening tool. So that's a really big deal.
I think 2 things. One, it would be, we're building Brilliant Baby and the whole Oakland Promise on a pretty impressive amount of philanthropic money, but that will not be with us forever. And so I think we need to look at ways to institutionalize these opportunities with public resources. And I've been just a sponge listening to the way you all are exploring Medi-Cal reimbursement and holistic care and looking more holistically at health indicators. I would love us to arrive at a place where there was a way to use Medicaid and CHIP funding to support both the enrollment and potentially the financial coaching, which is that parent stress intervention, with that resource. So that would be one. And then also there's been work over the last many years about pursuing a strategy of having a college savings account for every baby born in this country, so that every child, as sort of part of their birthright, gets that first investment towards their education. And I think that if we had that opportunity and if it was perhaps progressive in terms of the resources that go into those accounts for kids from low-income backgrounds, we could see a much broader impact for our kids.
Alan?
So, not completely surprisingly, I will say that I would like to see parity for primary prevention. So we've talked about parity. We've talked about parity in a lot of different areas. Parity for mental health. You know, all of these are really important. And you know, the stepchild in this, so to speak, is primary prevention, which is something that not enough attention has been paid to, and not enough funding has gone for. The second the second change that I would like to see in this, well, actually builds directly on Scott's question before, and Perri's response, is that I'd like to see us recognize that the core outcome of early childhood parenting interventions is parenting, and that we should be able to elevate promotion of parenting and the parent-child relationship. The idea of relational health is one that I've seen people say, and having actually parity for parenting, and to elevate that to the point where it is something that we realize is the thing that we are looking to make happen. And once it does happen and we enhance that relationship, we've actually done the thing that we are trying to do. And there are lots of other programs and approaches that are going to be needed to do the rest, but this is what we're doing.
And you can close this out, Perri.
Okay, well, I'll say the predictable quick thing, and then I'll try to say something slightly larger. It would not surprise you to hear that I would like to see the various mandates for literacy promotion, positive parenting on the periodicity schedule, reimbursed, taken up by other states for Medicaid funding, and generally institutionalized so that they're recognized for the important projects that they are. But if I'm going to say something even bigger than that on a policy level, I would like to see everyone in policy understand that you cannot, especially with young children, separate out health and education. Health, that there is no health for young children without development and learning, and there is no talking about development and learning for young children without talking about health, and on to include relational health and the health of the family. And I would like to see that reflected in the way we think about policy and who is around the table talking about those issues, because I don't know how we divided them or who divided them, but they're not separate.
So do we have time for any more questions, or are we done? We're done? Okay, we'll have to be in break. Thank you all very much. Thank you,